Welcome everyone to the Heart Valve Society interview series. As you know, in this series, we will connect with experts in our field to share valuable insights and discuss fascinating topics. Before we dive in, I would like to remind you that membership of the Heart Valve Society offers a host of benefits and opportunities, and I urge you to visit the website to see how you can get involved and to learn more. We're also thrilled to announce that the next meeting of the Heart Valve Society will take place in Chicago, Illinois in April 2026. We'll be following this with more information later on. It is now my pleasure to introduce our honorable guest for today's interview, Dr. Daniel Holloway. Dan grew up in Vancouver, British Columbia, where he completed his undergraduate and graduate degrees at the University of British Columbia. Following his medical degree at the Queen's University in Kingston, Ontario, Dan completed his residency training at the University of Calgary and a fellowship in Northwestern University, Chicago, Illinois, in mechanical assist devices and transplantation. Dan is currently an assistant professor at the University of Calgary, a staff surgeon in the Department of Cardiac Surgery, and at the same time is the program director of cardiac surgery. His clinical practice involves complex adult cardiac surgery and includes minimal invasive aortic surgery, minimal invasive CABG, VADS, and TAVI. He's a recognized expert in the field and is a coveted proctor and mentor in Canada. Dan, I would like to welcome you today, and we will proceed after I have an opportunity to introduce Philip. I am accompanied today by Dr. Philip Castleman, who I am sure for most of us does not need an introduction. Philip is an internationally recognized expert in robotic and minimally invasive cardiac surgery. He is currently a member of the European Association of Cardiothoracic Surgery Council and is chair of the acquired domain of the AACS. I have known Philip for a long time, since we were medical students and residents at the Catholic University of Leuven in Belgium, and I'm honored to have him present here today. He's currently based at the AZ Zurg, formerly the OLV Hospital in Aalst, Belgium. I would like now to start the interview by turning over to Philip and let him ask the first question to Dr. Holloway.
Thank you so much, Kisham. Hi, Dr. Holloway. We have not met in person, but I'm sure we will at some point in the future. It's a real honor for me to participate in this interview, and I really would like to thank the Heart Valve Society and Kisham for giving me this opportunity. Today's topic is right anterior thoracotomy aortic valve replacement. And I would like to ask to Dan, the first question would be that how did you learn yourself this technique, and what do you consider that were the most important successive steps in acquiring this technique? Did you go directly from sternotomy to right anterior thoracotomy, or did you go in between through J sternotomy? Tell us a little bit about your pathway in minimal invasive aortic valve surgery, and how did you come to this procedure?
Okay, well, thanks for the invite to be here. It's a pleasure, and happy to discuss this. So the pathway for me involved training in. It actually started in residency at University of Calgary, where the minimally invasive valve surgery was starting around that time when I was finishing my residency. And that was so Dr. Bill Kent and Dr. Andrew Maitland at that time were doing these RAMT thoracotomy AVRs. So I did get some exposure there. And then during my fellowship at Northwestern, with Dr. Chris Merlasery. He was also doing them there. So I had some exposure during my training. And so that was, I think, important for developing the kind of the fundamentals of the approach. When I came back to practice, the minimally invasive was still starting to volumes were increasing, and there was a high clinical demand. So early on in my practice, I stayed with sternotomy AVRs and developed my practice there with the intention, though, of doing minimally invasive. And my practice did evolve into that. This was under the mentorship of, at that time, it would have been Bill Kent in Calgary, who was doing it. And we did some cases together. And then eventually my practice turned into doing higher and higher volumes. Now, I suspect we'll talk about it more in the future or in the coming up, but I, it is very important to be strategic starting a practice into minimally invasive. And by that, I mean by choosing appropriate patients and preoperative planning. So that was my strategy early on.
Okay, so if I understand well, you went directly from sternotomy to right anterior thoracotomy. You did not go through J sternotomy or any other procedures?
I do. So I I did have exposure to upper hemisternotomy as well. Um, I still do those on occasion, and I did at that time as well. But the mini thoracotomy was and is the majority of the minimally invasive practice. So I think there is a role for the upper hemisternotomy with certain anatomies, and then for other anatomies, the thoracotomy is the preferred route.
Okay. So, Kishan, if you allow me, I would like to expand a little bit further on that,
Sure.
because
Yeah.
these days we have a multitude of approaches for aortic valve replacement. You have the standard sternotomy, which obviously most surgeons who are interested in minimally invasive surgery don't perform anymore unless there is a strict anatomical indication. But we have the J sternotomy, you have the right anterior thoracotomy, we have the transaxillary approach, we have the thoracoscopic approach. So then, can you give us some insight whether you personally perform these different type of procedures and whether you feel that one minimally invasive approach over another offers something extra, or in which conditions you would rather go for one or for the other? Or do you think that a surgeon should not master all of them and go by one or two of them to solve most clinical issues that we encounter these days?
Yeah, so I do think these are all fair game for surgeons to acquire the skills and have these as tools in the toolbox. And the deciding factor really, I think, should be the anatomy of the patient. Is we can develop these skills and then apply it to when we do our preoperative planning. Well, what's the best way to get a new valve into this patient? And if that's sternotomy or upper hemisternotomy or thoracotomy or lateral thoracotomy, what that comes down to is their anatomy. Where is that aorta in relation to the chest wall? Where is the annulus and the valve? And what's the best way to get in there with the least, well, we do want it to be least invasive and the least amount of morbidity. And so specifically, if it's a patient has an aorta, very close to the posterior table of the sternum, that sets itself up well for an upper hemisternotomy. If a patient with the aorta a bit more to the right, and the anatomy sets up for a RAMT, right anterior mini thoracotomy, that is certainly my preferred route. Depending on the orientation of the annulus in my preoperative planning, where that annulus is, that will help me determine how far lateral that incision will be, whether it's an axillary or more an anterior thoracotomy. So this is all predetermined on preoperative imaging, and that's what I use to try to determine, well, what's the best strategy for that individual patient.
I would fully agree on that one. So that does mean also that you perform CT scanning on every single patient that's planned for aortic valve replacement?
I do, yeah.
Yeah.
And that actually has changed over the last few years. Initially, I was a bit more conservative with that, But what I found in the current era, you know, a lot of these patients are also being considered for TAVI, so they're receiving high quality CT imaging for that purpose as well. And also, I find it very essential for planning for minimally invasive surgery.
Okay. If you anticipate that you need to enlarge the annulus, what would be your attitude towards which minimally invasive procedures to choose from?
That's a great question. If you know, and this again, it comes back to the benefit of preoperative planning is if I'm going to do a root enlargement, I really don't want that to be a surprise. I really want to be able to know that in advance and plan it out. There are certain times where if I'm expecting extensive work in the root, that I would just opt to do a regular sternotomy and get full access of everything. Um, I have done root enlargements through the right anterior mini thoracotomy. I think it's an acceptable approach for that. You know, that posterior part of the annulus is part that is visible and it is possible to sew a patch there. Um, so that I would consider that in certain cases. Um, I've had to do it unplanned, and that's not obviously not the preferred way to do it. But it can be done. Personally, I'm a bit more conservative if there's something like endocarditis or something at a root abscess that requires a lot of patching. In those cases, I would opt for more, you know, a sternotomy.
I would agree on that one. I think we're very similar practices if I hear it. Yeah, okay. So yeah, personally, if I anticipate an aortic root enlargement, I stay with the J sternotomy. I know it is possible to do so through even transaxillary approaches, but it doesn't make things easier, and sometimes it's a bit unexpected. Kishan, did you want to add any questions or any thoughts on
Just to follow up on your question there, if I understand it right, the surgeon, to keep to your initial question, should be able to master most of these techniques. Is that right?
Most of these for Dan, right?
Yeah, great. That's what I understand from Dan, right? That the surgeon should be able to do all of these techniques and not just
Yeah, I
one.
would say it behooves us to acquire these skills. These are ways that we can help tailor the surgery to that patient. And absolutely, I think these are tools that we should have.
Yeah, and for the younger surgeons or upcoming surgeons, what Philip and Dan, what would be their approach? Should they first do the J sternotomy and then move on, or should someone go directly from a median sternotomy to the RAMT?
Yeah, that's a good question, you know, and because I did, you know, the upper hemisternotomy was very commonly used in Northwestern, so I did have a lot of exposure to it there. You know, in my own practice, I do use it occasionally, but not routinely, and so um, you know, that being exposed to it early though probably still was influential. So that I suspect it still was an important part of my training and learning curve was doing it in training. Um, you know, could somebody go straight from sternotomy to thoracotomy? I think so, if you had the right mindset. But the hemisternotomy is also a useful tool to know, so everybody probably should know how to, or you know, be comfortable with that approach as well.
I agree, yes.
Yeah, I would agree on that again, Dan. I think we have really very equal views because first of all, I don't think it's absolutely necessary because, I mean, general surgery residents these days don't learn to operate the gallbladder anymore through laparotomy. They just go directly via videoscopy. So that should be feasible also in cardiac surgery. However, there's quite a few tools you need to master before you can safely apply them to your cardiac surgical setting. So therefore, you need to be quite confident with all these different tools. But again, I think from my point of view, to answer your question, Kishan, is that I think the surgeon should at least have some experience with either of these techniques. But obviously, it's like everything in life. You have some personal preference. Whenever you have done the different techniques, you have some personal preference for one technique over the other. And I do have to admit also that if I have to do extensive root work, I just stay by the J sternotomy. If I have a root enlargement, I J with J sternotomy. Endocarditis, either J sternotomy or full sternotomy, because you don't always know what you will expect. And as Dan has said, if you need to do a multiple patching, that may become quite cumbersome. But you need to know the limits of your procedure, I think, and also the advantages of the different techniques. And in some instances, you can have an advantage of switching to a different technique. And even so, you don't perform that one every day. If you have enough surgical background, you can relatively easily switch from one technique to another. That would be my point of view on this matter.
I totally agree, yes. If you don't have anything more to add to that question, I will ask Philip to move on. I think he has another question to ask to Dan.
Yeah, well, Dan, it was just a little bit further now on the in my personal practice, I had to change my cardioplegia administration in order to be able to change techniques. The reason being, we were still using old-fashioned cardioplegia, which had to be repeated every 20-25 minutes. And so I changed to Del Nido because that gives me more time and not to bother about re-administration and stuff like that. So my question to you would be, did you have to change? I'm just giving the example of cardioplegia now, but that could apply to other things, perioperative factors also. Did you have to change anything substantial in your technique that you had learned while you were a resident or in in your own early practice to be able to be more comfortable to perform these minimally invasive approaches?
It's a good question. I'll answer it in two ways. There's some technical things that it comes back to what you mentioned about building the skills. So for me, femoral access, is a big skill set that's important for this. I personally do percutaneous with closure devices similar to TAVI, and I guess the TAVI experience comes into play there. So the femoral access is a big part of it for this, doing that safely, with obviously as low complication rate as possible. With cardioplegia, I'm a fan of Del Nido, so that didn't change too much for me. I do use Del Nido um, for all my valves anyway. So that's one part. As just in a bit of an aside on that, I think that planning cardioplegia with many thoracotomies is very important, especially on AI patients. So that's a real technical consideration, is being able to know, well, listen, I got to be able to rest that heart really well, and we can't compromise that. So that's certainly something that needs to be well thought of in the pre-op planning to make sure that we have a good cardioplegia strategy for all these. And then the other part of it, though, is a bit more philosophical with doing the minimally invasive, and that's coming in with the mindset of that there are certain times where this AVR will be more challenging from a technical and an exposure point of view than it would have been through sternotomy. And it's the mindset of accepting that it will be more challenging, but it's worth it for a multitude of reasons, I believe. But that mindset of going in and then persisting to get that good result.
Yeah, I agree, fully. So now that you have you build up your own minimally invasive experience, how do you teach it to residents in training? Or how do you function yourself as a mentor to other trainees?
Yeah, so that's a great question. I'm the program director of our training program, so I do have a real interest in training, but this is also a
And a
challenging,
responsibility also.
yeah, exactly, and an obligation. And
Yeah.
these are the people that may operate on me one day. So um, that's my motivation, I suppose. But it is a challenging um, operation to teach residents because it's tough to see from the assistant side. So, when I'm operating, for them to see exactly what I'm doing is a challenge. And if it's, a senior resident, then I'm going to let them do the case. Well, I really want to see what they're doing as well. So It's a challenge, and and the part of the strategy there is the incremental thing. So, the vascular access or the thoracotomy, the parts of that can be well supervised. When we get into the actual aortic valve replacement part, well, in order for me to have to let confidence that a resident is able to start doing that, obviously I need to see them doing AVRs in other scenarios, open sternotomy, things like that. And then it just comes down to, um, you know, l- watching them and supervising them do what they're able to do at their level. But it is a challenge that, that's just the limitation of that small exposure site.
Do you add a video scope to your procedure in order to facilitate visualization?
It's a great idea. I haven't for the AVRs. The my only reservation with that is adding one extra hole for the camera port, which really not too big of a deal. That might be a strategy, especially with the small cameras nowadays, to do. But I haven't done that as of yet.
Would you advocate simulation labs prior to applying this in the clinical setting? Or
Absolutely. Yeah, thanks for bringing that up. So we do a lot of simulation, both so there's some great uh, silicone models of chest wall and aorta, and so the residents actually do that on a regular basis. And then also just using the long instruments. We have
yeah,
instruments that are available for the residents to use to practice on. So the residents certainly need to be comfortable with those instruments. And then um, the, the 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 simulators are great for learning the approach and the visualization. So yeah, that's a huge part of that training process.
that's one thing I used in my own building up my practice of minimally invasive surgery, is that from the start, I started to use long shafted instruments through regular sternotomy in order to be able to handle them properly, both for aortic valve replacement and for mitral valve procedures. And it actually helps a lot because you can also, and also step-by-step percutaneous even cannulation with sternotomy well, because I'm a bit older, so when I learned it was really the beginning of minimally invasive surgery. So no one had large experience. There were no simulation models. There was no other tools. So, and that's how I went step by step to acquire those things. So that when I really went for the minimally invasive procedure, the only thing that changed was the size of the incision, but the cannulation was under control. The instruments were under control. The knot tying was under control. Now these days we have core knot, but that in those days we didn't have those, so we need to learn knot tying and stuff like that. So I think there's a lot of issues, a lot of things you can master before you really get into the real procedure, and I think it's important for residents to do so.
I think that's a great point. Yeah, absolutely. Yeah.
Yeah. Okay.
Okay, I think we'll move on now to the next question, unless you had another question in this area here, Philip. I'm sure you
I think
have.
I have asked most of my questions already, but I think that, well, we asked the question on the CT scan also. Maybe an important point is also, what do you consider to be contraindications for these procedures?
I think that's an important point. Which patients wouldn't you operate on?
Yeah.
Well,
So
not through mini.
You're right.
yeah. Yeah, that's a good question. So there are patients who I think, their anatomy is just not appropriate. And this is a conversation that I have with them in clinic is, I do think there's benefits of minimally invasive, and whenever possible, I think that should be the goal. But there's some people where the anatomy just isn't suitable. And what it comes down to is the conversation I have is, at the end of the day, it's not worth it for the patient to compromise anything. So we can't compromise the safety and we can't compromise the final result. They need to have a valve that's working perfectly well, and we can't do it with any increased risk, or the safety profile has to stay standard. And so there's anatomic considerations where say, well, listen, I can't do this. The exposure isn't going to be good. There's going to be some sort of compromise, and then those patients should not have that minimally invasive surgery.
Can you give a
So
few examples of those? Because I think that's quite interesting for the people who will follow this
yeah.
seminar.
So yeah, so specifically, and it relates mostly to the location of the heart and valve and aorta in relation to the chest wall. So if it's somebody with a very deep chest, a barrel chest, maybe a COPD chest, something like that, where that aorta is very deep inside, it can get to the point where it's just very far away.
Yeah.
And on CT imaging, on an axial slice, typically what I want is from aorta to chest wall around 9 centimeters to the skin. And you can if you fudge it a bit up to 10 centimeters or so, it starts getting pretty hard. And if it's at 11 centimeters, it gets pretty regrettable. So 9 centimeters is my cutoff there.
So that's
Um,
to the right anterior chest wall, right?
Correct, yeah.
Yeah.
And then there's other anatomic considerations I do as well. Um, an aorta a little bit over to the right side is helpful. If it's way off to the left,
Yeah.
that can be a challenge.
Yeah.
If it's a less than a centimeter from the sternum, getting the clamp up there can be a real challenge.
Mhm.
Um, so those are all aorta chest wall things, but they can really make the operation more difficult. Personally, if there's significant calcium on the aorta, I won't do a minimally invasive or at least a right anterior mini thoracotomy for that. And the reason why is I found there when I get in there, there isn't a whole lot of flexibility on where exactly I put that clamp.
Mhm.
And if there's a block of calcium there, that could be avoided if I had a sternotomy or hemisternotomy. But
Mhm.
then I'd rather do that approach and be able to move the clamp in a slightly different spot. So
Yeah.
calcified aorta, I'm fairly wary about. And then a very deep chest. Very obese patients, it depends. Sometimes their aorta anatomy is good. I think those are patients that really benefit a lot from avoiding a sternotomy. So on an obese patient, there are certain times where I think they're still very well suited for a mini approach. But again, it does come down to the actual dimensions of that chest wall and where that aorta is. Because if it's too far away and just too deep, then you lose the benefit.
Yeah. And then there's obviously also, at least from my practice, what we talked previously about endocarditis. I think anything that's limited to the leaflet, it's okay. But anything, at least from my point of view, but anything that goes beyond the leaflets, as soon as the aneurysm is involved, I tend to use a full sternotomy because you never know for sure where you end up, how deep the abscess goes, if your trigonum is affected, yes or no.
Yeah.
You have to explore the mitral or things like that, and that is more cumbersome, at least
Yeah,
in my
I
opinion.
I agree with that. And actually, I'm a bit more conservative there on and any endocarditis. I don't do the mini thoracotomy
Yeah.
just because I'm wary that when I get in there, it'll be something different and worse than I expect.
Yeah.
Um, Redo aortic valves. I most likely won't do a mini thoracotomy on.
Yeah, I would
A
agree.
reduced sternotomy, I will if they had a previous cabbage or something. I find that actually works fine.
Mhm.
But the one contraindication there is if they've had a previous REMA harvest, especially if the REMA is patent. Um, based on
Well, if it remains a pedicle trema.
Well, yeah, or if it's in situ, if it goes under the aorta, you know, it,
It's okay.
I probably still wouldn't actually, but I've encountered a case where the REMA was draped over the aorta, and
Uh,
when I got in there, it was not ideal. So I
yeah.
basically, if they've had a REMA harvest, I'll avoid the mini thoracotomy.
Okay.
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 So we
Well,
have
I
had,
think,
pardon me, go on, Philip.
yeah, well, Kishan, I think I've run through most of my questions. I'm not sure whether you had any more questions.
Well, I think we have covered quite a lot. We have had some good insights into how one gets trained, what we should learn. We have got some good hints about the procedure itself, what to avoid, and how it's done, and some caution that we should follow. Uh, Perhaps, so we are in the stage now with the surgeon starting. And I don't know whether Dan wants to add anything as to how quickly one should convert.
Yeah, I have a quick comment on getting started. We talked about, training and mentorship. That's very important. Having proctors, I think, is very valuable, having a proctor come in. The other part of it, though, is in the pre-op planning, I think it's important to be very strategic on which patients to do to start a minimally invasive, say, aortic valve practice. And my recommendation would be to use the CT imaging to pick ones that have very favorable anatomy, and don't pick the really challenging ones first. If it's a really deep chest with a really small caliber aorta and AI or something like that, all the things stacking up against you, don't do that as your first 5 or 10 or maybe 50 even. Is pick ones that you think will be relatively straightforward from an anatomic point of view, and there still will be ones that are harder than you expect, and then go back and look at the CT again and try to figure out why that was harder than you expect. But try to set yourself up for success, and then there will still be challenges along the way, and there'll be a lot of learning along the way as well.
I think that's a great point, Dan. That is really what we missed and we didn't talk about so far. So, and then the other issue that Kishan just raised is also important. At what point to decide to convert?
Yeah, good question. So this also comes back to the important principle, I think, of not compromising safety or the result. You have to be able to give them the best surgery they can get. And the bottom line is if you can't do that, then you have to do something to enable that. And if that means converting, then so be it. You have that obligation to the patient to give them the best valve possible. Now, I think you can minimize that conversion rate with preoperative planning, sometimes and also persistence of just working on getting that exposure a little bit better until you can see what you need to see, and you can get a lot done that way which is working at it still. But the bottom line, when it comes down to it, if you have to convert, you have to convert. And actually, one other thing I would say before that is there's times where I've had to just increase the incision size. And sometimes that's the solution to getting that last little bit of exposure that you need. So
There are
one
a lot of little tricks that you need to master or that you learn by yourself as you are developing your own practice that can help you to increase the visibility, to facilitate your technical procedures, so to speak. But I would agree that as soon as safety is compromised, whether it's from technical exposure, whether it's from myocardial protection, very important, neurological point of view, whatever, that then you gotta have a safe procedure first, and that's. But there is very few instances. If you build up your experience, there's very few instances where you still need to convert. You may have, very exceptionally, a conversion at the end of the procedure where you have some bleeding and you can't reach it. That has happened a couple times to me, but that's not very frequent. And
Yeah, I agree. The actual conversion rate it should be actually very low.
yeah.
Yes, and I think that's where the planning comes in, the things we have covered, and setting your indications and things. So I think that one of the takeaway messages is just that, getting acquainted with how you plan your operations, which patients you shouldn't approach, and who you should start with when you're initiating your practice.
Yes. And that's actually a good role for a mentor as well, is to go through that planning, to talk about it before, review imaging, and come up with those plans.
Yeah, and I would think, if I'm not a director of a training program, but you are, that it's probably important whenever somebody starts to operate on their own, that you go through their plan preoperatively to check that did they think about everything, did they take this or that into account, and in order to minimize risks, again, to offer the safest surgical procedure possible.
Yeah,
Totally.
absolutely.
Yeah.
Now, Dan, and both Dan and Philip, I will give Dan the opportunity to answer. The first thing when you talk to older surgeons, like Me and Philip, maybe we started earlier, but one of the responses is, why should I do a minimal invasive aortic valve replacement when I can do it just as safely? I mean, I can do it well with a median sternotomy. What would your answer be? Is it purely aesthetic? How would you answer that surgeon?
Yeah, the aesthetic of it actually is probably one of the smallest parts of it for me, the smallest benefit. There is evidence mounting showing the benefits of minimally invasive, and we have an article up for review right now that will show some of the objective benefits. But lower transfusion rate, quicker recovery, quality of life factors all play a role. And anecdotally, I can tell you one of the big motivating factors for me is seeing how well the patients do postoperatively.
Yeah.
And when they come back and they're happy, they've been able to, recover quick and get back to what's important to them. And, for some people that's work. And this time of year, a lot of people is golf or driving or, using their arms early on. So it's the quicker recovery in the weeks after surgery and how well people do and how happy patients are with it. That's the big motivating factor for me.
That is not always so easy to measure. So
Mhm.
so it comes to yeah to living through their procedures, so to speak, and they usually compare one another with different with a neighbor or a family member or a nephew or whatever who underwent cardiac surgery also, and this you have to see the patients to believe it, and if surgeons keep on saying to me, listen, why would I need to do that, my patients do well, then I mean you have to see it yourself in order to be able to believe it. And it's I always say to the danger though is that patients think it's the difference between 100 and 0. That is not true. There is always
Mhm.
discomfort, whatever surgical procedure you do. There may be some pain, there may be some discomfort, there may be some atelectasis, there may be some pulmonary issues or secretions or whatever. But overall, the speed of recovery, the comfort during revalidation is substantial. Yeah,
No, I totally agree. And having spoken to patients sometimes after that procedure, I think an important point is that they're thinking. Patients they don't talk to me as if they had a big operation.
yeah,
They think they had a small procedure, and they get back to doing the things they can do
and yeah.
relatively quickly because they're not hindered by this thought, oh, I'm a very sick person and I just have to recover from a big operation. So
I
I
would
think
agree. I would agree on that one. That psychologically, it's also important for patients because they don't know what the difference is between a sternotomy, transactally, thoracoscopic, or whatever. As long as they have a minimally invasive procedure, they're happy.
yeah. So I
Yeah.
think we have covered quite a bit in this interview, and I hope those who have joined us will learn a lot from it. And Philip, is there anything else you would like to?
I think we covered most parts.
Yes.
You could still talk about what's the next level. Do you perform bentals routinely, invasively? What about David procedure and stuff like that? But I think it's maybe a little bit beyond the scope of this program or this interview. So yeah, whatever.
Yeah. Dan, is there anything else you would like to add?
Um, no, well, I know there's some people doing really big surgery like bentals and other reconstruction stuff through minimally invasive. I think that's incredible. That's my practice is really not that at this point. I think it's amazing that there's people able to do that with great results. Um, the but yeah, that's to me that it's impressive, but not something I'm looking to do in the near future for sure.
Well, I'll tell you, I do bentals on a selective basis, minimally invasively. Yeah.
Hmm.
But I usually go into the fourth intercostal rather than the third then, just to have a little bit more space.
Oh
And
yes.
that's if you choose your patients on a selective basis, then it's it's quite feasible. I have no experience though with David procedures and their coup procedures doing this. But
So there seems to be a lot that we look forward to.
sorry?
Seems to be a lot that we can look forward to.
Yeah, but there is not many surgeons that perform valve sparing procedures minimally invasively, I can tell you. Anyhow.
Yeah.
Yeah,
Well,
so
it is you know, it's an exciting time with minimally invasive surgery. I think it's, you know, as surgeons, it's important for us to make sure we're doing what's best for the patient. And when it's a small incision and a quick recovery, then I think it's a tremendous thing for them.
yes, I am in total agreement. And I think Philip will agree with me.
Absolutely.
We were both trained, we were both learned from a lead, one of the pioneers of minimally invasive surgery, Dr. Van Herman.
Yeah, correct.
And so he, at one time, used to say to me that this is and this is 15, 20 years ago, this is the future of cardiac surgery.
Well, I learned minimally invasive aortic valve replacement when I was a fellow at the Cleveland Clinic with Toby Cosgrove.
Mhm.
And then he also did the mitrals through adjacent anatomy. But when I came in Austin, the port access program here started in '97. We were among the first centers in the world, together with Leipzig, to start invasive mitral surgery.
Yes.
And that helped a lot to build our practice and our experience. Yeah.
Well, I would like to first of all thank both of you for being here with me this morning. Dan, it was very educational, and I think a lot of people have learned a lot from what you have said, as well as Philip's questions were very pertinent. And I hope that we will be able to hear more from Dan at either the Heart Valve Society or the AAX in the future as his practice improves. For the rest of the audience, I'd like to thank you all for joining us for this installment of the HVS June interview. And we hope you have found the interview just as interesting as we have. Philip, would you like to say a few words before
I
we...
can only add that I entirely agree with what you said. For me, it's an honor to be part of this panel, and I'm looking forward to meet Dan in person at some meeting or another. I'm sure we'll have enough things to talk about. And same with you, Kishan, because it's been a while we've seen each other.
That's correct, yeah.
Come to Copenhagen. I mean, the ESCTS meeting is in Copenhagen later this year, early October. So you're more than welcome to join.
Yes, let's look forward to that. I will try to plan that. And
Wonderful.
now I will say to the rest of the audience to stay tuned for more interviews in this series. And we look forward to connecting with you all sometime soon. Thank you,
Thank you
Philip.
very much. It was a pleasure to join you guys today.
Thanks
Thank
to the
you.
Heart Valve Society. Thank you. Bye.
Bye.